All right, thank you everybody for joining us back here. I have the pleasure of introducing Grace Maloney, who is a physiatrist. Am I pronouncing that? I'm working on the language, physiatrist. An interventional spine specialist at Barrow Neurological Institute. She is board certified in physical medicine and rehabilitation by the American Board of Physical Medicine and Rehabilitation. Her expertise includes interventional spine care and sports medicine. Her practice includes vertebrae augmentation, spinal cord stimulation for chronic pain, and spinal injections for degenerative disc and joint diseases. Dr. Maloney earned her medical degree from the University of Illinois College of Medicine in Chicago. She completed her residency in physical medicine and rehabilitation at Stanford Medicine in Redwood City, California, and an interventional spine and sports fellowship at Barrow Brain and Spine in Phoenix. We are very fortunate to have Dr. Maloney with us today to teach us about her expertise and how this all affects you. May I please introduce Dr. Grace Maloney.
Thank you for the introduction. I'd like to thank Jill and the Acromegaly community for having me here today to speak. It's such a wonderful opportunity for education and sharing different perspectives. So hopefully I can provide a new way of looking at something today or a new piece of information to some of you that you've never heard before. But my focus today, I treat all sorts of different pain in all different joints and all different parts of the spine. I'm really going to be focusing today on the kinds of pains that would be relevant in acromegaly. So musculoskeletal type axial joint pains, spinal pains, and we'll get into it from here. So I want to go to the next slide. There we go. So I want to start with talking about what is pain. As a physiatrist, you know, the way that I look at pain, we can look at it in different ways. We can look at it as just a number that makes it nice and standardized. Is it a 1 out of 10 pain? Is it 10 out of 10? You know, this is a scale you've all seen, but it can be hard to quantify pain in just those measures. Pain is something, it affects people's quality of life, it affects people's ability to be independent versus needing to rely on others, to require adaptations to life. Chronic pain is something that has long-term mental implications. It causes depression when it's not treated, not understood, not addressed. And every person's experience with pain is unique. So when we're trying to treat someone, that's something that I like to look at, and I think it's important. Someone can have the same exact condition, but need a very customized treatment plan, and we have to look at how their experience is. So going kind of back to the basics, at least in terms of talking about pain, how does acromegaly result in pain? So we have increased levels of growth hormone, increased levels of IGF-1. Those go systemically and affect multiple organ systems. The system that I'm concerned with are the bones and the joints. So spine, cartilage, and inflammation involved in these areas, as well as degeneration. So you have cartilage degeneration, bone spurs, and arthritis as a result of acromegaly. In patients, in a standardized set of interviews, and in patients generally with acromegaly, there's a higher incidence than in the general population for age-matched controls of complaints of shoulder, hands, hips, knees, foot pain, spine pain. All these complaints are there at a higher incidence. Even in patients who don't, there are radiographic evidence findings that can correspond to arthritis related to acromegaly. So just because we always talk about just because someone has arthritic findings on x-rays doesn't mean that they have pain, but you can have a higher incidence of both in this population. Some of the arthritic findings present in acromegaly, it's interesting because some of the findings can be similar to arthritis, but others are unique. So increased incidence of excess bone formation resulting in osteophytes, but the osteophytes tend to be worse in the arthritis of acromegaly compared to primary arthritis in a similar primary arthritis patient. There's also joint space widening type findings that can be present versus we're used to looking for just joint space narrowing in primary arthritis. But again, it depends on the joint and the presentation. What's interesting also is that in acromegaly, even in patients who have a controlled condition or in remission, they are still at risk for an increased incidence of having arthritis years later. So this has been looked at. So this kind of brings about the question again, and that importance of early diagnosis and treatment. How early do we really need to diagnose and treat acromegaly, or what does the future hold in terms of preventing these types of arthritic changes and pain from evolving? All right, so at least in looking at what contributes and what's present in the bone and joint changes involved in acromegaly, mouse models can provide a useful model for looking at some of these. So you can have your wild type mice without overexpression of growth hormone and IGF-1, and then these lab created mice that overexpressed kind of to control for other factors. A mouse joint is not the same as, a human knee joint, but you have a femur, there's a tibia, there's a knee joint, there's cartilage, there's a kneecap, and the researchers were able to look at some of the differences present in the mice that were not overproducing growth hormone as compared to the ones that did. And it was obvious the kinds of bony changes present in the joints in the mice with overexpression of growth hormones. So increased inflammatory markers, increased sensitivity to mechanical and thermal stimuli. So, these are the things we would be associated with more pain and possibility of pain in a joint. Differences in the bony network remodeling and the unhealthy joints as compared to healthy joints, and then increased cartilage loss and chondrocytes, which are the cartilage producing cells. Those also appeared differently in the mice that had excess secretion of growth hormone. All right, so talking about bony remodeling, this is a very simplified picture, but just to kind of review. So bone health and bone remodeling, it depends, if we're making it simple, we think about there's two kinds of cells involved in bone remodeling. There's osteoclasts, those reabsorb bone, break down bone, and then there's osteoblasts, which are kind of the builders of bone. When you have a good balance between these two in healthy bone, you have a healthy structure. If bone is fractured, if it breaks down, it can be rebuilt and regenerated with a normal structure. When osteoclasts are overactive and the osteoblasts are not functioning properly, and this is some of what is likely seen in acromegaly, then the bone networks do not form properly, and there can be weakness as well as arthritic changes. So kind of just a diagram, just another way of looking at, the changes present in an arthritic joint, bony remodeling, inflammatory factors, reduction of cartilage compared to a healthy joint. Another thing which I found interesting is that there's skeletal fragility can be present in acromegaly. This is not present in all patients, but some patients this can happen. There's increased risks in certain subsets of patients for having fractures. The kinds of fractures I see the most often that I can do something about are compression fractures. And these kinds of fractures they may be incidental where it's just something that happened over time, same as what I see in my most typical, the patients I see most commonly with compression fractures are osteoporotic female patients, with declines in hormone levels with age, bone fragility becomes an issue. But in acromegaly, bone fragility can become an issue too. Does it present acutely or chronically? That depends on the patient. Something as simple as coughing, sneezing, going over a speed bump can cause an acute type of fracture, or findings of fragility could be something kind of incidentally noted on X-ray imaging or MRI later on, where there's decreased height in the bones looking at them, but the patient doesn't recall any kind of traumatic incident. But certainly, again, patients with acromegaly and abnormal bone remodeling are at risk for this. What's complicated about this as well is that, so for osteoporotic decreases in bone density, we can test that using DEXA scan, the standard bone mineral density testing. This is not useful in acromegaly. So oftentimes someone won't realize the bone fragility until they actually have a fracture. Here's just sort of a demonstration. You can think of trabecula and bone networking as being healthy, and when it's not healthy, the scaffolding isn't working properly. This is not exactly a picture of what it looks like in acromegaly, but the idea is that unhealthy scaffolding leads to risks for fractures. And, the way the formation of the scaffolding is going to differ between someone with osteoporosis versus someone with acromegaly-related bone fragility. Right. So how do we manage pain? The good thing is that even though there's differences kind of at a molecular level and an etiology level with different sorts of arthritis, a lot of the different kinds of strategies that we can use for managing pain are the same. And of course, these are all things that automatically are generally tried, but it's always important to start. So with more conservative treatments. So the conservative treatments that I'm always recommending and trying to see if patients have incorporated into their treatment program is physical therapy, lifestyle modifications. I always talk to patients about different medications, trying to minimize side effects, but improve quality of life with using the minimal possible. Injection therapies are possibilities. And then I'm going to spend some time talking about ablations today, which can be a great option for some patients. And neuromodulation is being kind of like a new and ongoing area within pain management that continues to develop. Surgery is always the last option for treating pain, but sometimes can be necessary as well. So as far as lifestyle factors, anytime that a patient has pain in a joint or an area of their body, it never hurts to strengthen as much as possible the musculature around the area of that joint to offload the joint. People need very customized exercise programs at times to be able to do the strengthening. This is strengthening, and these sorts of things, of course, become less effective as the arthritis worsens. Severe arthritis is not going to respond as well to this as in earlier stages, but maintaining high levels of activity and high levels of strength can help really prevent someone from experiencing the declines in quality of life that come along with pain and rapidly worsening arthritis. And then maintaining a good weight or healthy weight when possible, of course, helps to offload the joint as well. If you walk around with a backpack sometimes, you might only have 5 or 10 pounds in that backpack or on your shoulder, and you can imagine how uncomfortable that can be at the end of, an hour or a couple hours of walking around. So even losing 5 to 10 pounds can make a difference for some patients in terms of how they feel pain. Talking about medications, so over-the-counter medications are always something that can be tried. When you walk into any drugstore, you'll see tons of different topical and pain medications. A lot of them are the same thing. It's just different branding. But if you kind of I always recommend looking at the back of the box and seeing what it is that's in that formulation that you're getting. Probably the topicals with the best kind of evidence for helping with arthritis would be a topical NSAID like a diclofenac gel. Just because it has the best evidence, though, doesn't mean that it helps everyone. And there's plenty of people that some of these medications are not helpful for. Medications with less evidence, but that can still be helpful. Menthol, camphor, capsaicin, kind of those kind of icy hot type topicals that are a distraction from the pain. And people really have to try and see what works well for them. Lidocaine patches can be helpful at times. Some people have had relief with CBD ointments, glucosamine, arnica. and other sorts of topicals. And there's some limited studies for some of these. Some studies show some benefits, other studies do not. So there's no clear recommendation for most of these medications aside from topical diclofenac gel, oral meds like acetaminophen and NSAIDs, ibuprofen and naproxen. Those are things that patients can try that, have a little bit better evidence. I'm always, even though things like Tylenol and ibuprofen are over the counter, I still am always cautioning against overuse of these and being careful as well, because patients that do take Tylenol for long periods of time, even within the recommended daily dosing guidelines, some patients will develop elevated liver enzymes, showing that there is some overload on the liver from processing these. So it's good to kind of switch out medications and minimize use where possible. There's, of course, GI side effects and renal side effects that can be associated with use of ibuprofen and naproxen. So definitely important to just work using multiple ways of pain management and trying different things. When we go to prescription medications, there are prescription NSAIDs. So the benefits of some of these, like with the meloxicam and celecoxib, are longer half-life, so not needing to take medication as frequently. These still do have side effects potentially on the gastrointestinal system and on the kidneys, so they have to be monitored. But it can certainly be useful to patients. And then there's categories outside of what we consider typical pain medications. So the tricyclic antidepressants and SNRIs, those are more commonly thought of as antidepressant medications, but lots of medications have uses across the indication for which they were originally developed or used. So we use these a lot in neuropathic pain, but they can be used. There are some studies that show some benefit in chronic pain syndromes as well, and in arthritis. Opioids are, of course, the last thing that we want to use, but in small doses or with limited side effects, if we can find an optimal regimen for the patient, then they certainly shouldn't be off the table in terms of helping a patient to function and maintain good quality of life again. Injectable medications. So any joint in the body that we can find, for the most part, we can inject, and with varying results at times. So steroid injections, hyaluronic acid injections, platelet-rich plasma injections. I'm going to kind of go through these and talk about it. Steroid injections are very satisfying in a sense in that people can get instant pain relief from the anesthetic that's put in with the medication. The steroid typically takes a few days to kick in, but it can provide weeks to months of relief. So that's a very nice thing for a patient that's been having severe pain to be able to have this. But there can be, while there's benefits to the steroid, the side effects and the risks also have to be weighed. So steroid, used occasionally doesn't really have significant side effects or problems, but of course, with frequent use, there are more side effects and problems that can occur, especially in patients with diabetes, for example, elevating blood glucose levels, adrenal insufficiency with overuse of steroids. The problem with steroids too can be that in a patient with early stages of arthritis, but still having good cartilage, a steroid can be damaging to the cartilage over time, and the anesthetic can have damaging effects on the cartilage over time as well. But it can be helpful. So hyaluronic acid, that's that's a lubricating type substance. It can be naturally found in the body. There's lots of cosmetic and other kinds of uses for it, but we can also inject it into different joints to try to lubricate the joints. And this is something that can be helpful with pain as well. And then PRP injections, which most people have heard about at this point, is basically using your own blood to isolate the platelet-rich component of the blood and re-injecting that into an area of the body. This doesn't actually promote regeneration. I mean, there's been lots of studies done, but it doesn't promote regeneration in the area. Rather, what you're doing in these cases is putting in more growth factors, signaling factors. It kind of modifies the environment of the inflammation, and it can sometimes be as effective as steroid. in sort of bringing down the inflammation and managing pain control. So all different options. When arthritis gets to a certain point, however, then again, we have to go to the next step. So as far as, we're going to kind of move on now to talking about arthritic back pain. So how do we treat arthritic back pain? I don't use just steroid injections alone for this. I'm going to kind of go into talking about using nerve ablations. So the thing I like about nerve ablations when it can be done is that no steroids involved in nerve ablations, and it can provide kind of a more long-lasting relief of pain depending on the area that we're targeting. So there's 3 predominant regions in the back that we can target to do ablation. So if you think about nerves, there's thousands of nerves in the body. The nerves that I target for these sorts of procedures are dependent on where I believe that a patient has pain. So the SI joint is located down towards the lower part of the spine. That's where the sacrum and ilium come together. This can be an area that's involved in pain frequently for individuals with arthritis. And it's an area that I can potentially ablate with varying efficacy. The vertebrogenic end plates. So there's a nerve called the basivertebral nerve. I'm going to go into this too. So this is a newer procedure that's had some great results. It's one of the newest procedures that we do in pain management. And when you have inflamed end plates and degeneration, we can burn the basivertebral nerve and eliminate pain or greatly reduce it from these areas of the bone. The lumbar facet joints is probably the most common sort of ablation that you'll hear about because this is the most common ablation procedure that's been done up until that generally is done. Yeah, even with the recent development of new ablations. Okay, so I'm going to start with talking about lumbar radiofrequency ablations since this is so commonly done. So the facet joints are joints in the posterior aspect of the spine. They provide stability, help to maintain alignment along with ligaments and other elements of the spine. These tend to become arthritic in everyone with age, but of course with those with primary arthritis or with arthritis associated with acromegaly, they're going to be prone and at more risk of becoming arthritic. So each joint has 2 nerves, as we understand the anatomy, has 2 nerves that go to it, and they come off exiting spinal nerves at the levels adjacent to the joints. And so what I do when I want to see if these joints are involved and if blocking and burning these nerves can potentially help a patient is I will do test blocks on the nerve. The idea behind the ablation is actually destroying the myelin coating and portions of the nerve itself to eliminate the pain signal that's carried by the nerve back to the brain. It's not going to fix the arthritis in the joint, but it can eliminate the sensation of the pain associated with the arthritis, which can be dramatic for individuals. So we do 2 sets of blocks before making a decision to move forward with an ablation. I put needles over the areas anatomically where the medial branch is expected to run, and we put contrast over those nerves to highlight them, and then we put a numbing anesthetic over it. After that, a patient who presumably came in with pain, if the blocks are working, should be able to move nearly pain-free, sometimes has more range of motion. And we track these improvements over a period of hours and have the patient come back and let us know how they did. If the patient does well, then that's when we move on to a second set of test blocks, hoping for similar results in efficacy, and then we can make a decision to ablate. Every single person is different, so it's hard to predict with an individual how long exactly the ablation is going to last for and provide relief. But the data shows, and what I've seen in practice, that people have months to years of relief. And typically I'm seeing around 1 to 2 years of relief in the majority of my patients that I do this procedure for. And, the best test again for figuring out if facet joints are related to a patient's low back pain or pain anywhere in their back is to actually do the blocks and see, because there's other sources and pain generators in the back that can cause pain, like the discs and vertebral end plates, SI joints, like we talked about. So this is just some data from a study kind of showing how patients were doing 12 to 24 months after their radiofrequency ablation. So as you can tell, at least in this group of patients, over 50% of the patients had at least a 50% relief, and that's kind of matches with what I see in the practice. SI joint ablation. So the SI joint, like we talked about, sits down lower in the back, and it has its own specific network of nerves and regions that we target when doing blocks as well. So the L5 dorsal ramus comes off of the L5 exiting nerve root, and then we have lateral sacral branches for the posterior innervation that can be targeted as well with test blocks. What can be tricky about this joint is that there can also be there is an anterior component of innervation thought to come off the anterior component of the lumbosacral plexus. This is not something that can be reached by interventionalists, and these nerves cannot be burned. So results with doing this kind of burn can be more of a 50-50 type thing, and that's sort of what small studies show. But certainly in patients that respond well to the blocks and the burn, they can do quite well. So this is just some imaging showing the different ways of doing an SI joint diagnostic block, either injecting lidocaine or some sort of anesthetic directly into the joint, or placing needles over the nerves that, like we talked about, in that posterior network to test and see if an ablation may be effective. The way we burn, and this is kind of helpful to see kind of how a burn looks around the needles. So the way we actually burn is we put in special needles and insert electrodes, and the tips of the needles are actually heated up by energy passed through the electrodes to actually cause heat and create a lesion. So the larger the needle is, the greater the lesion in the area will be. For an SI joint, we can create a strip lesion shown on the left, or we can cluster needles around the nerves and sets and do individual burns at each area. All right, next I'm going to talk about basovertebral nerve ablation. So this is an MRI here, and that's what we're looking for, or that's what we're looking at when trying to see if a patient is a good candidate for basovertebral nerve ablation. So this patient probably has well, actually, you can't tell. You can't tell just from looking in imaging if someone has pain. But assuming a patient does have back pain and has this sort of imaging, the source of the pain seems quite clear. And in this case, they have disc degeneration and also have the degenerative type of end plate changes called modic changes, which are inflammatory and provides a marker that they may benefit from this procedure. This graphic here shows a representation of the basovertebral nerve within the vertebral body and branches off of that nerve going up to the end plates, which presumably have some inflammatory changes going on if we're targeting the nerve to burn it. So you see the representation here of the electrode coming in and introducer needle being used to access the vertebral body and introduce that electrode right in the region of the basovertebral nerve and to ablate it. This is some long-term data from studies on basovertebral nerve ablation, and these are the results of the data in the treated group. So you can see that patients on average starting up at a pain score around 7 over time and persisting over a period of years. After having had the procedure done, patients did have a significant, on average, overall decrease in their pain scores. So the longest data that we have that's published right now is 5-year data, but that's quite significant for patients that have been living with back pain. So we have a couple more ways in which it's not only the pain score that we use to evaluate quality of life and pain, but we also look at the ODI, so that's another source of measures. So the study looked at that as well. So it's a disability index and kind of uses other questionnaires to grade quality of life, ability, and ability to perform certain tasks. So a higher ODI corresponds with more disability and lower with less. So you can see in the 5+ year data that patients had a significant decrease in their disability index scores as compared to baseline. And over 66% of patients were reporting a greater than 50% relief in pain at 5 years of follow-up. So neuromodulation, this is sort of the last thing, a last measure that I recommend to patients. I don't use this often at all, but I just want to talk about it today because it is a big thing in the world of pain management and medicine. So I kind of describe it to patients. We have a pacemaker for the heart, and this is sort of like a pacemaker for the spine. So there's an implantable pulse generator that can be implanted and hooked up to electrodes that go up inside the spine, but posterior to the spinal cord, and they modulate the pain signals transmitted from the spinal cord to the brain, essentially. So when you can modulate these signals, electrical signaling, there's a possibility of modulating pain. And these signals are adjustable from cell phone-sized devices. And it can be quite effective in some patients. But again, this is something that, is a measure of last resort because this is going to be an implantable type device. The technology has changed over the years. People used to be able to feel the sensation in their back or in their legs, and that was part of the principles behind use of the device and blocking the pain. But now the technology has progressed to the point where patients no longer have to feel those uncomfortable sensations, but still can get some pain relief. So how exactly does it work? Well, there were studies done, in the development of the technology. So certain areas of stimulation in the thoracic spine will correlate with certain areas of interfering with pain in other areas of the low back. The lower down that you go, the more the stimulator can be used to try to control pain in the thigh, legs, lower extremities. This is sort of just another representation here. This is a cross-section of a graphic of spinal cord anatomy showing the dorsal columns, which is the area along which those spinal cord leads would pass posteriorly. And the signaling interacts with those dorsal columns to affect pain signals traveling. And then last but not least, as far as procedures, kind of going back to that, speaking about fragility fractures, in cases of acute and severe fractures, with having abnormal bone remodeling in conditions of osteoporosis and bone fragility, sometimes these sorts of fractures don't heal well. So if a patient has chronic pain ongoing and still has ongoing evidence of acuity within the fracture, then fractures are something that we can fix or stabilize by putting cement into them, and that can be very helpful for the patient. So in older fractures, a curette or some sort of device can be used to create a cavity within the fracture to fill with cement. In the middle of the screen, I have a picture of a balloon that can be expanded within more acute fractures to make a cavity within which bone cement can be deposited. So what are the future directions for arthritis and acromegaly-associated arthritis? It's hard to know because this is a rare condition when compared to primary arthritis. I do suspect, that the future involves development of new pharmacologics. Some of it may parallel treatment of primary arthritis since there are similarities in terms of osteophyte formation, cartilage degeneration, et cetera. And there are clinical trials and new medications coming out in the world of arthritis that can prevent worsening and progression of arthritis early on. So just like with pain medications and usage of different drugs for different conditions, I imagine that there's going to be studies in the future trying to apply the new drugs that we find for primary arthritis and seeing if there's efficacy. But again, it's also going to be important to work on diagnosing and treating acromegaly earlier and finding how to prevent these arthritic changes from presenting in the first place. Yeah, any questions? Yeah.
Great. Well, thank you for this great talk. My questions are mostly from the beginning of the session, but you talked about in acromegaly patients, we can have a joint narrowing. What are some of the consequences of joint widening, sorry.
So I wouldn't speak to knowing the exact, I think I'm talking more about what's interesting is there's unique radiographic appearances that appear. So maybe perhaps the joint space appears wider, but I still do believe, and based on other studies that there is cartilage degeneration. So it's just that appearance of joint widening, but arthritis still results in bone spurs that are mechanically irritating and inflammatory, which probably still contribute to a lot of the pain.
Great.
Oh.
Just one more question.
Mm-hmm.
You talked also about the osteoclast dysfunction, impaired balance. Does that mean we are more prone to develop osteoporosis in the future?
So yeah, that's sort of the interesting thing is that it's sort of is a form of osteoporosis that acromegaly patients can be at risk for, but it's different from the osteoporosis present in postmenopausal females. So there can be that risk of increased bone fragility, but there's not really a way right now or a good diagnostic test to see how weak someone's bones actually are, but there is a higher incident rate of fractures within the population.
Great, thank you.
Thank you.
This one, is this working? Yeah, is this working? Okay. This is David. Donald.
Okay, this may sound crazy, but this is what I believe. I had a back injury. They attempted 5 surgeries. None of them gave me any relief. And I did find some relief some 15 or 20 years later when they discovered I was adrenal insufficient. Is it possible I had pain in my adrenal glands that was mistaken for spinal? Now, I did have the spinal injury, but I don't think that's where the lion's share of my pain was coming from in hindsight. What's your opinion? Is that even possible?
I would say in general that it's not, unfortunately, it's not unusual that back surgery doesn't fix or address back problems. And the evidence isn't great for, it depends on the cause, but generally that's why most spinal surgeons prefer, and we all try to avoid back surgery and only use it as a last resort. And try other measures first. Hormonal imbalances in anyone, and it depends, it's very patient specific, but can cause someone to not feel great in so many different ways. I can't speak to an individual case, but when not feeling well, all sorts of pain can be worse.
Thank you. Here's another question.
So you had mentioned PRP, but what about like the stem cell?
Yeah,
What is your opinion on all that?
Right. So stem cells right now, recently, the FDA actually has recommended and posted guidelines against the use of stem cells. Stem cells is sort of a tricky topic. So we don't really have access to stem cells, to live stem cells right now. The only stem cells that you can get are from your own adipose tissue or from a bone marrow aspirate that has a few stem cells in them. My opinion and kind of the data for stem cell injections and PRP kind of match or along the same lines in terms of, I don't know, they've been compared to head, but when compared to steroid or compared to other things, they're both not particularly there's never any evidence of regeneration with either of those. And it's hard for the stem cells. Stem cells don't stay alive in an environment in which they don't initially come from. So essentially, if you look at studies and what happens to the stem cells once they're injected into a certain area of the body, or if you look at them in a laboratory setting, if they don't have that perfect set of conditions in which to survive, those stem cells that we're living are immediately dead. And it's really the growth factors from within the stem cells and from within that, whatever you're injecting along with the stem cells into the body that probably has the effect rather than the cells themselves. But we don't clone stem cells here in the US right now and clone out the lines and use them for injecting. That's not accessible right now. And the FDA is cracking down on practices that are using stem cells aside from the patients themselves for injections.
Do you think that anybody that was getting the stem cell injections, do you think it can have adverse effects and kind of make things worse?
The adverse effects that I've heard of and seen are mostly more from the infectious risk or risks from processing. The cells themselves are putting like a wrong kind of tissue into a wrong place, but I haven't seen that so much for the spine or axial joints. That I wouldn't say I don't do a lot of that though, as the evidence behind it isn't great. So.
Okay. And then one last tiny questions. How do you feel about the TENS units for helping pain?
So TENS units kind of work on the idea of distracting from the pain over the area. They stimulate muscle contractions and over an area of pain. It's sort of an adjunct to any other sorts of treatments and therapies that can be done. So if it works for an individual, then I say that's great. And I do recommend it for some people.
Thank you. There's another question.
Yes, what is your opinion on the ablation process for like sciatic nerve?
So the sciatic nerve has both sensory and motor components. Your sciatic nerve enables like your hamstring flexion, movement of your foot and everything. So we don't actually have a procedure to ablate the sciatic nerve, because then you would lose a patient who had that procedure done would lose the function and use of their legs. So when I am evaluating and treating a patient for sciatica, the things I tend to be looking for more are, is there an entrapment of the sciatic nerve, or is the problem actually coming from higher up in the lumbar spine from spinal nerves contributing to the spinal nerve? And that can mimic, that causes a sciatic type pain. So I'm generally looking for that and trying to treat a nerve entrapment or inflammation. We don't burn that nerve though.
Thank you.
Yes, and as far as prevention for osteopenia or osteoporosis, with calcium or supplements, what are your best answer to what we need to do to prevent that? Exercise, weight loss and all that, but as far as supplements or calcium?
So, and especially in an individual with acromegaly and someone who's also a female and postmenopausal, the risk for fractures becomes even higher between having the two conditions. For osteoporosis, the best evidence for postmenopausal osteoporosis, the best evidence is for medications that reduce the loss of bone, and also medications that promote the new formation of bone. Those have the best evidence for, and particularly the ones that are injectables and promote formation of bone. Those are the ones that have the best evidence really for helping reduce the risks of fractures. And then the improvements in bone density after doing a course of those medications can be maintained with anti-resorptives. I always recommend for all my osteoporosis patients, the basic daily supplements with vitamin D and calcium, but unfortunately, those don't really seem to have much of an effect in and of themselves on the risk factors for compression fractures, because there's the hormonal imbalances associated with postmenopause and other factors going into these conditions of bone fragility are really what's causing the issue and not a lack of calcium, vitamin D, or other supplements.
This one's working.
But then with follow-up with that, so if someone has osteopenia with acromegaly, would it be best, when would you start that or?
Right. So I try to have endocrinologists that I work with closely to help me manage those conditions and get the patient started on I would want the patient to work with an endocrinologist and get started on an anabolic agent in a way that was appropriate, probably as soon as possible to prevent the worsening of the condition.
So the osteopenia doesn't go to osteoporosis?
What's that?
So you would start it when the patient is just having the osteopenia and not quite osteoporosis yet? Or would you wait until the bone density scan gets to the osteoporosis?
So, I mean, there's the insurance side of things, and then there's the clinical opinion side of things. So the, that's sort of, my opinion would be that the earlier that a patient was started on medications to improve their bone health, the less at risk of fractures they would be. Most insurance guidelines would say that to be on medication for, for osteoporosis, they have to meet criteria for that. So but yes, I would recommend to be on agents for bone health as soon as possible.
I wanted to ask you what can be done for joint laxity and I guess the effects of acromegaly on ligaments and tendons in relationship to that laxity.
That can certainly be a tough issue to manage because there's not really any known way to tighten up the joint laxity. So depending on the patient and the kind of pain or issues experienced due to the joint laxity, I'd probably recommend a mix between, and again, it depends. For certain joints like a knee or an elbow, maybe bracing. For something like a neck, probably more focused on physical therapy and ways to keep muscles strong to minimize the effect of the laxity. But that certainly it's certainly something for which a number of interventions and kind of conservative measures would be tried and kind of to see how it worked for the individual.
Thank you.
Any other questions for Dr. Maloney?
So for this weekend, it looks like this is probably the only time we're going to be bringing up the topic of bones. And that's one of the biggest things that are augmented in us. And I'm really curious, I can't find the data on this. Do you know if there's a general, like a percentage of deviation in acromegalics compared to non-acromegalics of how much more bone we have?
So I did see some data from a small study just showing an increased risk of fracture, but I can't quote that number right now because I don't remember it. And then I do remember, from what I was looking into, that I guess that's the problem. There isn't a good way to look at the bone density or to quantify that specifically.
Is there another question back here?
First of all, thank you for your presentation. During your presentation, you spent a section on the problems with your back and the lower back. If a patient were to have problems with more upper back of the neck problems, just in my reading, I felt like something called spinal stenosis. The remedies or the kind of the alternative types of treatments that you suggested, would that be similar for the upper spine?
Oh, okay. Yeah, so I definitely did spend a large part or most of the presentation just focusing on the high yield low back stuff. But of course, there are areas that I didn't touch in with this that relevant to arthritis in any kind of condition affects the cervical and thoracic spine as well. So with cervical stenosis in particular, the issue is the excess arthritis affecting the spinal canal itself, and potentially impinging on the spinal cord and exiting spinal nerve roots. And that can cause, so for a patient, with axial pain, I tend to focus on cervical facets, just like I did in the low back, with lumbar facets. But if nerves are significantly impinged by the excess bone growth, then what I tend to start seeing in patients is pain radiating down the arms, or when it's severe enough, it can cause neurologic symptoms affecting the extremities below the level of significant spinal stenosis. So in those cases, depending on the severity, I usually use epidurals to try to bring down the inflammation around the level of stenosis if it's not too severe. Or surgery can be needed in some cases of cervical stenosis. But if pain is axial, and again, if it's related to facets and not stenosis, then ablations are an option for the neck as well. So very, very patient dependent. But yes, I would say the treatment would be somewhat the same in some cases and different in others. Yeah.
Any other questions?
Hello.
Hi.
You're very interesting. Thank you for presenting. So for people that have, where their numbers are under control and under maybe biochemically controlled, but are continuing to have like bone and, joint issues, the endocrinologist should continue to look into this, or should that person be referred to somebody like you? It just seems like it
Yeah.
doesn't go away.
Right. So the problem is that I believe from what, I'm reading and kind of seeing, it's that initial event of the onset of the arthritis that leads to the problems further on down the road. And once that starts, then we're just always kind of treating the progression of it. And it's this with primary arthritis, it's the same too. Arthritis never really seems to get better. It either stays the same or it gets worse, unfortunately. And the more bone spurs and more degeneration of cartilage you have in an area, the more it makes the joint prone to inflammation and worsening of the inflammation and further degeneration of the cartilage from the mechanical component of the arthritis. So at that point, then hopefully someone like myself would be trying to help you manage the pain, but we wouldn't really be looking for ways to necessarily be treating the acromegaly further at that point.
Okay,
Yeah.
got it. Thank you.
Mhm.
All the way across.
So kind of following on that last question rather neatly, obviously, many of us do not have direct access to a facility like this, where maybe we would be referred to someone with broader knowledge like you. When trying to find support, you mentioned individualized workout and fitness plans, physical therapy. Do you have any tips or recommendations to find somebody qualified to look at the unusual?
Right. As far as specific physical therapy and training recommendations, you probably want to be looking at a physical therapist, the most experienced one you can find that has the most experience, if not in this sort of setting of working with patients that have acromegaly, at least someone that has a background in working with various types of medical conditions and you need someone that will listen to your concerns and maybe do some work to understand more about the condition. But at the same time, the arthritis, even though the origin of the arthritis may be different than primary arthritis in that sense of pain, the treatment a lot of the times ends up being very similar in terms of needing to strengthen. So if you can work with a good sports therapist who's open to listening and has experience in working with patients with a variety of conditions, you'll probably end up with a good experience.
Any other questions? Okay, last request. Any other questions for Dr. Maloney? Okay,
Thank you, everyone.
yeah, thank you very much.